So, welcome, Francisco. How are you today? I'm so glad to see that you were able to make it.
Yeah, thank you so much. Thank you for having me today.
Well, you're a very busy man, and I've been following you on YouTube, so I'm very interested to dive right into what your whole journey has been. And just tell us a little bit about yourself.
Yeah, so I'm a medical oncologist. I've been working on breast cancer for since my fellowship for a couple of decades, and breast cancer has always been really my passion. Doing research, patient care, and recently I about 2 years ago I started. Um, Created my own YouTube channel to mostly focus on patient education,
Hmm.
so not so much on physicians. Where
Right.
we've that's what I was doing for the most part of my career, was involved in lectures to other physicians,
Hmm.
as you know, CME and other things. And I think I thought there was a gap in how to communicate very complex ideas or concepts or data to
Hmm.
cancer patients. So that's what I've been doing in the last couple of years.
Well, as I mentioned, I think one of the places that I saw you first was on your YouTube channel, and I have to say, I think that your YouTube channel is probably something that all physicians that are interested in giving education to patients should really take a look at because you've done a stand-up job of it. In fact, I often will watch them because I want to hear how you explain things. It's always nice to hear the little nuances on how different doctors use different examples and scenarios. So bravo to you.
Thank you so much. Yeah,
Yeah.
it's been fun.
So, just diving into that a little bit more, I understand the background. You wanted to provide this other educational piece. Did that come out of your own practice, finding that these were the concepts that patients didn't understand?
Yes, it's when a patient is diagnosed with breast cancer, it's so stressful.
Hmm.
You just explain things, and a large part of that is not, they don't retain it, that they don't understand sometimes the whole picture what we're talking about. So
Hmm.
having a resource explaining what kind of breast cancer, what staging is, what kind of treatments, what
Yeah.
therapy is, hormone therapy, and so on, I think is important. um, Lately, the many patients have told me they have actually um, found it very helpful to be able to go back and say, "Oh, now I understand this a little
Yeah.
bit better." And I think I try to put some images and videos and so on to explain how medications work, why we use them.
Right.
Try to stay away from data, like real data.
Yeah.
But yeah, it came.
That's our job. It's our job to interpret the data.
Yes, that's right.
But I actually find it interesting the topics that you do choose. And one question, do you when you meet a new patient or your regular patients in the clinic, do you tell them to go see your YouTube page or do they just find it?
I've lately I feel more confident now, and tell them. I was a little bit shy to.
Uh-huh.
I felt it was a little bit of a almost self promotion. But one patient told me recently, no, this is good. You're not, you're doing this as a voluntary contribution. It's not.
Right.
You're
Right.
not
You're not monetizing on it. You're not charging the patients to go watch it. Right.
monetizing anything, and it's just for pure education. So I'm now, lately I've been telling some patients, but for the most
Hmm.
part they discovered me because I was just testing the water and see who was interested or not. I heard it's important to have some sort of organic growth, and you want people to watch it who are really interested.
Right.
Patients are looking for these things all the time. If they
Yep.
find it, it's an issue because there are not so many physicians actually talking to patients in YouTube. I
Yeah.
think 3 or 4, uh,
Yeah.
but in the whole world, that's not much.
No.
And now that YouTube actually allows for multiple dubbing in multiple languages, I think it's going to be even bigger impact as long
Sure.
as they discover you. That's one of the issues. So I get ideas from the patients, from what they
Right.
ask in the clinic, what I think is interesting. But again, it's a little bit risky when you think about what's interesting to you, or
Hmm.
in this case, because what we need to do is what's interesting to the patients. what's interesting to our audience,
Right.
and questions you hear in clinic and so on. It's been
Hmm.
the the basis. But being an academic physician all my life, I
Right.
sometimes kind of take a tangent and go into things that are more data driven or so on. And I find the ones that are simple and address specific issues that concern
Right.
patients are actually the ones that are most successful. I
Yeah.
recently did a video about explaining what invasive breast cancer is, and
Hmm.
about a month ago, and it had 20,000 views, the biggest, my biggest video in terms of, and it was a very simple topic to
Yeah.
explain what
Sure.
it is. So that's what I'm trying to focus on, what patients want.
Yeah, yeah. There are a couple of physicians that do a lot of discussion about the latest article that comes out and the latest data on antibody drug conjugates or what have you. But I think, as we've discussed in the past, I find that so many patients, to get to the level of discussing what an antibody drug conjugate is, we got to go all the way back to the beginning. You got to know what a protein and a receptor is first before you can even get to the more complicated medications that we're using. But it is interesting. Patients have become more sophisticated for sure.
I think so. It is so that's one of um, the main differentiators for us is to explain, like, yeah, I just did a video explaining what antibody drug conjugates are, for example.
Hmm.
And again, it's not easy. I had written a review article last year about that and tried to even use some of the images from that to
Right,
explain, but it is so difficult actually to explain something that for us looks very simple, right? You have
right,
antibody, you have chemotherapy, it's linked to each other and so on. But
right.
that's basically what I'm trying to do, not to so much going into 20 clinical trials, because
Yeah.
that's not.
Well,
Uh,
it just overwhelms people, I think.
yeah.
Do you have children?
Yes, I have one children,
Yeah. How old?
30.
30. So
Yeah,
I have three. My youngest is 19. She's a sophomore at Providence College, and she's studying neuroscience. And
nice.
I don't think she's going to go into medicine, but she loves the neuroscience. Anyway, I had this whole conversation with her. She's in this methods and statistics class. And then in her molecular biology class, they're studying HER2 as a protein. So she wanted to create something, a question, a statistical question with a hypothesis that she could then test out using some database or what have you. So I was
Yeah.
helping her do that, and realized that although they're studying HER2 and as a protein, the whole concept of how we utilize HER2 in breast cancer treatment, I mean, I ended up lecturing her for about a half an hour. But
Yes.
the thing when I walked away from that is I realized that I have to be able to explain it to her so that I can explain it to everybody else. Because it's pretty much that, a very bright girl studying science in college, that's pretty much the level that or lower that we need to aim for, because people don't necessarily know the lingo that we use,
No,
right?
I'm aiming for a much lower level than that.
Yeah.
Um, and that's been a challenge. That's been a
Yeah.
challenge, but I'm aiming to, high school or less type of level, because
Mm.
if most a lot of my patients would not understand it
Hmm.
at that high level. So I try to go down and use examples,
Yeah.
like little
Analogies.
antennas and the cancers.
Yep. I do. That's my antenna. That's my receptor. Yeah. So that's great. So you had mentioned the multilinguality, is that a word? The multilingual capabilities of YouTube at this point. Have you been translating or having your
Yeah,
videos
well,
translated?
now it does translate automatically to about 20 languages or
Oh,
more.
wow.
That's automatic. So once you select the auto dubbing feature on YouTube, it goes out. So it's really nice. Now, they don't do it for the older videos, and that's an issue. But since they started 6 months ago or so, uh,
Hmm.
and I don't know if everyone has it yet, but
Hmm.
it works for me right now that I get that in 20 languages. And also, so what I do afterwards when I finish the uploading, I,
Hmm.
if you want the subtitles in different languages, you have to do that yourself. And there is a way to do it automatically from the the original translation, the original
Interesting.
transcript. So I spent some time fixing the English because my first language is Spanish. I speak English. I've lived in the US longer than I've lived in Spain, where I come from, but I still have to check because of my accent.
Mm,
The computer doesn't sometimes, it makes mistakes sometimes.
yeah,
The other dubbing and subtitles and everything from the original, so I
right.
have to fix at least the subtitles to make sure it's good, and then you can check it and go into like 100 different languages for
Wow.
subtitles.
But
So
then you can at least check it in Spanish when it translates to make sure that it translated properly. It's
that's
funny.
that's
A,
what
li-
I do.
a little anecdote here.
That's
Oh
very
God.
good, yeah, for me, because I was thinking about doing either similar videos in Spanish.
Right.
A lot of my patients are Spanish speaking, and there is like 400 million people who speak Spanish,
Yeah.
uh, but in the world. But then I didn't want to confuse the channel with two different languages.
Yeah.
That was one issue. The other is, I didn't want to have a second channel, which you
Hmm.
can have that. And with this option, I think is the best option. You just do it in one language, let's say English, and then uh,
Right.
move it, check the other 20 languages. And it's not the same because if you speak Spanish or French, and it's probably better to do it on your own. It's like kind of you show your own bedside manner.
Right. And
You,
the colloquialisms are different
yeah.
also. Yeah.
So
We
some people told me I should do some Spanish videos. So I'll
I
probably.
think you're doing enough, Francisco. I think if as long as it's translating it for you, I think that's great. We have a running joke in my family. My husband is originally from Guatemala, and he's been here. We've been married almost 30 years now, so he's been here also probably longer than he was in Guatemala. And I swear, every year his accent gets thicker. I'm like, how are you doing that? I can't understand. So we have a running joke. If he needs to ask Siri something, he can't do it. She can't understand him. It's so funny.
So the
I know.
for example, I've done a few videos about HER2, right? HER2 therapy, HER2 targets, and it always gets it wrong. Like it would write, HER2, or I don't know how to say it. I think the computer has issues with the algorithm or
Yeah, sure.
with that,
Yeah, of
uh,
course.
but
But so let's transition a little bit. I'd really like to, you've talked about how you've created these educational videos for patients. And as you know, this is the Empowered Cancer Patient podcast. And so one of the reasons I was so interested in what you're doing is because I feel very strongly about empowering and educating patients as well. One of the things I talk about a lot in my own literature and in my own social media stuff is about how to navigate the system and how the medical system in general is not well set up for patients to actually navigate it themselves. And so I try to provide lots of information and education at this point, trying to help patients to navigate and how best to do that. So what kind of insider tips, being the chief of breast medical oncology at a Northwell institution, what kind of tips would you give to patients in terms of navigating systems?
navigation, cancer navigation is one of the most important areas in oncology right now, I think, for big systems. Northwell Health is one of the largest healthcare systems in the US, is the largest in New York.
Hmm.
We have, we're more than 100,000 employees, to give you an idea, 28 hospitals, 1,000 clinics, and it's a very large community-based center. We also have academic institutions in Long Island, Manhattan,
Right.
Staten Island, and so on. So it, to navigate within this type of systems is extremely difficult. Most
Hmm.
places now tend to stay in one system. In New York, there's probably 5 large systems, as you know. I don't know how many, but it's even within our own system. A few years ago, we found that it was extremely difficult to go from point one to point to once you have a diagnosis, where do you go? What do you do? So we set up a navigation system within Northwell that
Hmm.
actually is working quite well. So if a patient is diagnosed with, let's say, breast cancer, immediately the patient is contacted and told where she should go to be seen usually by a surgeon first, and
Right.
from there we move them to medical oncology, radiation, and so on. So it's working actually quite well, but it took
Hmm.
a few years to set it up, and now
Does each patient get their own navigator who they follows along with them?
so we have they're disease based, so we
Hmm.
have some patients don't need it and don't use it, but if we need, so it's not universal for everyone. We see
Hmm.
many patients, but we try to ensure newly diagnosed patients are directed, and then each department kind of does their own thing, and we are building the navigation system across different specialties. But the entry point, I think, is very important to when someone is diagnosed to know exactly what to do,
Right.
where to go, whom to talk to. Um, so
Uh-huh.
those are professional. Now we created that basically that position within Northwell.
That's great. What other kind of insider tips would you think of?
Well, so I only see patients with breast cancer.
Sure. Yeah.
So when a patient is diagnosed with breast cancer, um, it's important to talk to other people, other patients who had
Hmm.
similar experiences, so we also can connect them.
Right.
But getting a quick access to a doctor, I think, is the most important thing. They should. So there's so many things we can talk about, but
Yeah.
they want to know everything. They want to be educated. Uh,
Right.
what you are doing and what I'm trying to do is to educate them what happens when you are diagnosed, what's next, what's how to read what's a pathology report, what kind of cancer do you have, what stage. All these questions are important, so
Right.
having a
Right.
list of questions for them to go through
Yeah.
is
I
important.
actually think I have one. I'm going to put it up here with my QR code for that one.
That's great.
I have a free guide, the essential questions to ask your oncologist. So if anybody's interested, you can scan that, and they'll ask you for your email, and then it will get automatically sent to you. Um, but there's other things. There's more than just that, and that's what I've been trying to focus on quite a bit now. Is things such as for a young woman. What are my options in terms of hair loss and scalp cooling? What are my options for fertility preservation?
Yeah.
And things like that. And then another big hot button topic on social media I've seen is, am I going to go into menopause? And what does that mean for me? So, and then it's the post care, the supportive care afterwards
Mhm.
that I think is really missing. In fact, I feel like it should even be its own fellowship at this point, that we have so many millions of survivors. What is it? 3.8 million survivors of breast cancer in the United States right now alone.
Yeah.
And, there's not a good system that is readily available to the masses for this type of survivorship. And so, some woman might have gone rapidly into menopause and she's miserable and doesn't, and her doctor might not address it, and they don't have a system like you do that with like the good navigation and what have you. And it's tough. I think there's this big missing piece in our oncology care at this point.
Yeah. So younger patients in the last report of the American Cancer Society, actually, we've seen an increase in the number of cancer patients
Hmm.
who are younger, particularly in colon cancer, but also in breast cancer. And I've seen that. I've noticed that in my own practice. Why are we
Yeah.
seeing all these young people? I saw
Hmm.
a patient a couple of weeks ago who was 20 with
Yep.
DCIS, which is rare. She felt something, and probably the DCIS was an incidental finding.
Right.
It was
Right.
not explaining, but it is happening at a younger age. The majority of patients, of course, are older, so the median age is 60 approximately
Right.
in breast cancer, but there are more than 300,000 new patients diagnosed every year. This year, 315 or 16,000 are
Yeah.
expected to be diagnosed. Many of them will be younger, and they are special. They have special concerns. So
Yeah.
so we have uh, when we talk about surgery, we have our surgeons are very familiar with that, and there are some that are more popular in the younger population, and patients know know that. But so addressing the fertility issues, for example, is something
Mm-hmm.
that is super important. We often, especially for younger patients, we often have to give chemotherapy, hormone,
Mm-hmm.
suppression, and
Right.
ovarian function suppression, and so on. So dealing with fertility is one of the most important discussions before we start any treatment.
Yeah.
We have a fertility program just
Right.
in my office where I work at Meath. We have a full. They can see them very quickly, basically.
Yeah. Yeah. Yeah, we had a program like that at Memorial as well when I was there, and oftentimes either they would be seen by one of our navigators or one of our physicians and nurses, and then we would collaborate with the Cornell group for fertility. And yeah, they were always so accommodating. But still, even then, you're looking at waiting at least a couple of weeks before you can start your treatments.
Yes, I mean you have to delay treatments if they have to do egg retrieval
Retrieval, right?
and so on. But the important thing again for the patients to they're so anxious and want to do stuff. So the important thing is that they can be seen quickly and
Hmm.
have a plan. And then if you wait a couple of weeks, it's okay to wait a couple of weeks. But in the past, you would have to wait even a couple of weeks to see a doctor.
Right, that's true. So at least the access is better, but yeah.
Access better, and also technology has improved so much.
Hmm.
And they can do a lot of things today that they could not do 10 years ago,
Yeah.
5 years ago. So that's becoming very popular to do egg retrieval, and then we can do chemotherapies and so on, and plan for future treatments.
Hmm.
Also, I'm just actually this week. Today I was working on a video I'm going to post in a couple of days, to talking about the safety of becoming pregnant, getting pregnant after a diagnosis of breast cancer.
Hmm.
And there is a very interesting study called
Yeah.
Positive Study.
Yep.
Positive is the name, but where
Good acronym.
yeah, uh, younger women who were had breast cancer were treated for breast cancer and then are on hormone therapy. Hormone therapy was discontinued
Right.
for a couple of years to let them have a baby. The success rate for in terms of pregnancy was quite high.
Hmm.
The number of pregnancies was good, and there was no increase in the risk of recurrence by doing that. Many
Hmm.
women also used IVF, and in those women, there's a separate report last year from that. Those women who had IVF on the positive trial also did not have an increased risk of recurrence. So this is
Hmm.
really positive and
Right.
really interesting results. Um,
Right.
and I-
And I'm sure you read or you've heard about all of the latest issues with the menopausal hormone therapy. And now they removed the black box warning, which is going to throw half of the cancer community into complete turmoil because they don't know what that means for them. I just wrote a whole article. I have to get that out on my Substack. Um, but
that's an ongoing discussion because I mean we just
yeah,
had this discussion this morning at the tumor board, the breast
yeah,
cancer tumor board with surgeons and so on, and yeah, even if you get someone to give you a lecture, there are so many opinions in both ways that it's very hard to really understand. The issue of hormone replacement therapy, whether that increases the risk of breast cancer, whether it's safe or not, what kind. Um,
right,
you know,
right,
over so many years, we were following the women's health initiative, showing that there was an increase in breast cancer in women taking hormone replacement therapy. But even in that study, it is I think is true from my understanding of the study that women who took estrogen alone did not have an increase in breast cancer.
correct,
It was more
right,
the women with treated with estrogen and progesterone. So there is,
right,
I think there was a lot of fear about
Right.
about this. And
Well, there's been a lot of talk about how those results were probably misinterpreted as well, or misrepresented to the population. But the reason I brought it up was in conjunction to what you were discussing with pregnancy. If we can allow women who've had hormone receptor positive breast cancer to pause their tamoxifen or their aromatase inhibitor and stop their Lupron, get pregnant, have a baby, and it doesn't increase your risk of recurrence, one could also argue that those are very high estrogen and progesterone level states, right? And so why can't women take hormone replacement therapy? But it's so counterintuitive at this point. You know, when you spend half your life trying to block your patient's estrogen because you want to save their life and prevent their cancer from coming back, but yet they're tortured by being in menopause and they want the other therapy. It's I mean, we really need better studies. We need molecularly based studies with better markers and targets.
I think so, but it also depends on the type of hormone therapy we use. For
Sure.
example, if you have a patient who's in menopause and is taking an aromatase inhibitor where it's bringing the estrogen, the low amount of estrogen they make even lower,
Right.
and then you replace that with even a little bit of estrogen, to me doesn't make sense because you're
Right.
you remove estrogen, you're replacing estrogen. But at the same time, women who are taking tamoxifen, which is very effective in also premenopausal women with lots of estrogen,
Right.
are probably safe to take a little bit of estrogen. But all of these things are still evolving as to what to do, what's safe, what's not
No,
safe. So I
absolutely.
take it on a one case by case basis. But quality of life is so important that, since we're curing a lot of these women, we need to also think about quality of life. And
Yeah.
oncologists are always the ones saying no to these things. So I'm trying to
Right.
open.
But we're okay with vaginal estrogen, right?
Again, there is some absorption.
No?
So again, it depends. It's very. I don't think we can generalize. I think a low dose of estrogen is safe. There is other approaches like of course, first of all, there's many non-hormonal
Right.
approaches
Of
for hot
course.
flashes, vaginal changes, and so on. But even if you have to use a vaginal estrogen, there is, for example, this est ring that has very low absorption,
Right.
and that to me is one of the safest approach. Other creams
Right.
are absorbed more, but if a patient is taking an AI is different than tamoxifen, for example. But I had this discussion with a patient who had horrible symptoms, and she decided to use one of these estrogen creams. And I think as long as you use it for as less as possible, and it's okay. But I don't think it's a good idea. The sample you gave before is in premenopausal patients. It's different from you know in
Hmm.
after menopause. But
I don't know. That's a hot button topic, though. I think I've always been fairly liberal with the estrogen creams, the vaginal estrogen. I think I was part of one of the studies for Eastring at MSK, um,
the histamine is
and
very safe in my
and
opinion.
there was no increased risk of recurrence with it that we could
And
we
the
could
creams
see.
are
So
probably okay too. But
yeah,
taking
yeah.
hormone like doses, and then they're talking about these other formulations, and which really there's not good data in my opinion as to.
Well, that and Vagifem seems to be safe as well. I know there was data on that as well. But I agree. I mean, a topical estrogen, even if it's, hormone, um, what is the word? I'm blanking on it. It's not a synthetic or hormone. Even if it's real estradiol, there's a lot of argument now whether or not people should be able to take them if they've had a history of breast cancer. But like we've I think already decided we need more data, we need more studies, and I think that there's probably a much better way to study this than how it has been done in the past.
Yes.
In other words, these cohorts where they just observe them over time, some get it and some don't, and we wait and see what happens. We're in the world of molecular medicine now. We should be able to figure out markers and targets and be able to measure things that can tell us who it can be safe for and who it can't be. But
Yeah.
I keep screaming that into the wind. I'm hoping somebody's going to pick that up and start building that study for me. But
It's very complicated. Doing this type of studies is not easy because
yeah,
unless
no,
you
I agree.
um, you know now we know more about gene sequencing and polymorphisms and things like that
Hmm.
maybe I'm sure they affect differently. Different. Some people are more susceptible to some of these things than others, but doing this type of genetic studies in just healthy tissues is very difficult.
Yeah.
Or-
Yeah.
But I agree with you. We need to do better.
We need to do better. It's true. All right. Well, this has been a wonderful conversation. A lot of information for everybody here. What other things would you like to say to our listeners? We have breast cancer patients, we have all kinds of cancer patients, we have advocates, other physicians that listen, and so caregivers as well. What kind of things would you like to leave as a parting gift?
Well, I think it's important to 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 understand. I mean, cancer is still has such a powerful word, and
Yeah.
people are so afraid of that. But in some types of cancer, we've been able to cure many patients
Mhm.
with breast cancer and many other types of cancer. Others are not curable, unfortunately, and even
Mhm.
within solid tumors or breast cancer specifically, sometimes it may not be curable, but it still is treatable. So I think it's important to keep to stay hopeful once you have this type of diagnosis. I've also become more interested in learning more about Stoic philosophy, how to learn how to you know stay present,
Mhm.
focus on on today, and see what we can do today, and not get over stressed out about what's going to happen in the future, because that's really uncertain. So I try to integrate all of these things um, in my practice, and
Mhm.
um, to
How would you explain that to a patient? What do you tell them to do?
well, when they are when you have a diagnosis like cancer, the first thing that comes to mind is how long I'm going to live, or how, and nobody knows these things. So
Mhm.
I basically try to stay in the present, to enjoy what they have, be grateful, and
Mhm.
try to stay positive.
Yeah.
A positive attitude helps a lot. Also, it's important to understand another thing that we need to explain a little bit better, is the importance of clinical trials,
Yes. Thank
because
you for bringing that up.
that's, again, nobody wants to be a guinea pig, but at the same time, many people have benefited from being the first people getting some treatment that actually worked. Many of them do not work, so we have to be very clear about what we are trying to do, what's the idea or hypothesis behind a specific treatment. We do not use placebos in someone who's has advanced cancer, for example. We would
Right.
compare
Right.
a treatment with something that may be added to that, or better treatment, and so on. So the different phases, phase one, phase two, phase three, and so on.
Right.
It's important to explain that. Uh,
It is.
and then we
Have
have,
you did you do a video on that yet? Because I think that would be a good one too.
yes, yes. That's yes, it's gonna come up in a couple of weeks. So I'm
I
just
have a
thinking of
Substack
the things
article. I
I'm doing.
have a Substack article I just wrote on that. I'll put my link.
Yeah, my next few
Yeah.
videos, yeah, one of them is gonna be about explaining the clinical trials. Then yeah, I'm also trying to go into each specific subtype, because breast
Mhm.
cancer is not one disease, and this may be true, or is true for many types of
Right.
lymphoma. Is not one disease, there are many types, and so on. So in breast cancer, just having breast cancer is not enough to know. So they need to understand what kind of breast cancer they have, or what kind of
Mhm.
cancer they have in general. and
Right.
and as we do this type of educational videos, I try to focus on the different types. So you have triple negative breast cancer, you want to
Right.
know about triple negative breast cancer.
Mhm.
Tamoxifen is not going to help you, so you don't
Right.
need to worry about that. But immunotherapy might help you, and
Right.
and so on. So I think getting as specific as possible within your own type of cancer,
Yeah.
being open to clinical trials, is an important consideration.
Yes.
Also, try to get as much support, join support groups, get to
Mhm.
socialize with other people with the same problem. I think helps uh,
Yeah.
a lot.
I would often pair my patients. Of course, I would ask the patient first if she would be willing to speak to this other newly diagnosed patient. And I've made some connections for patients that have created almost lifetime
Yeah.
friendships at this point.
Yes, it's not very common, but I've had that experience as well. That I had a patient who had a pathologic complete response to neoadjuvant HER2 therapy given
Mhm.
before surgery, and this other patient who came with a very similar situation and
Mhm.
similar age and everything, and they talked to each other, and so that was very helpful.
Mhm.
So,
Yeah, it is helpful. So this has been wonderful. I'll let you get back to your very busy day. I really appreciate you taking the time to speak with us, and I look forward to seeing you soon.
thank you. Thank you so
Thank you
much.
so much. We'll drop all the information with the links to everything in the show notes as well. Okay?
Thank you so
Bye,
much.
everybody.
Bye.